Well, howdy everyone. I'm David Glazer, and I'm here to talk us through the new Comprehensive Care Joint Replacement Rule, what hospitals, physicians, therapists, and SNFs need to know about it, and then we're also going to cover a little bit about Gainsharing. The main Gainsharing discussion will occur at the end of the presentation. We're going to start off talking about CJR. Just the usual litany of announcements. Our April webinar, which will be April 13th, is going to be Advanced Provider-Based Billing. And there have been some significant developments in the provider-based world. And we'll walk you through those. I believe it's going to be Steve Beck, Katie Ilton, and Briar Andreessen. And they're really good on this provider-based stuff. The May webinar is going to be on mobile health type issues. And Ryan Johnson's doing that possibly with Catherine London. I think that's May 11th. While we're talking about joints, I will just as an aside mention we do have an expert here on medical marijuana. So if that sort of joint is your thing, Kevin Rich here knows a lot about that. And if you've got questions, we can hook you up with him. All right, let's get in with this. Oh, then just two housekeeping things. People sometimes struggle to find the slides. The email that had the log information has the slides. If you look below where it says additional information, you can print out the slides right there. So if you have the information, if you got that email, click there, you can print the slides. And if you have sound problems, you can dial in using the number Robert is typing. All right, let's. You can also ask questions via the chat box, Robert reminds me, and that's important. If you click on the chat box in the upper right corner, you can type things in, and I will do my best to answer questions at the end of the session. So first, an apology. This is an apology in advance, and I always tell you not to apologize in a speech, but you need to when you know what's coming up. I fly on a lot of CRJ aircraft, which is pictured here, and I will at some point say CRJ when I mean CJR. So I apologize. So what the heck is CJR? This talk is going to alternate between the really big picture, sort of strategic, and the down in the weeds detailed, because the CJR program's got a lot of both. So the Comprehensive Care for Joint Replacement, which CMS in its infinite drop a letter all the time rule is now abbreviating as CJR, is a program that's going to make a hospital financially responsible for a bundle of care. The bundle starts at the date of admission and ends 90 days post-discharge, and it's going to apply to all A and B payments for total knees and hips, which are DRGs 469 and 70. Now, a couple of initial points. So first, I often refer to it as a 90-day bundle. That's not quite right because the period in the hospital counts. So it's the time in the hospital plus 90 days. Second, in many ways, calling it a bundle is really misleading. And we'll explain more about that, but it isn't truly a bundled payment. Instead, there's a target price that's calculated. And in a couple slides, we'll look a little more at how that's done. But CMS figures out what they think the total cost of the bundle of care, and that's going to be the hospitalization, the therapy you get after, the physician services provided, any IRF services. So this bundle, they're going to figure out this is what we anticipate that bundle should cost. We're then going to look at what the hospital's actual costs are, and if it's lower than that bundle, the hospital gets a bonus payment. If it's higher than the bundle, the hospital has to pay money back, with an asterisk on those two things, which is there are also some patient satisfaction and outcomes measures, and depending on how those score, a hospital can lose the bonus that it would otherwise receive. Now, this program is not nationwide yet. It only applies in 67 metropolitan statistical areas. That's what an MSA is. And if you're in one of those 67 MSAs, and we'll talk about those in a second, you are in CJR as of April 1st. And I didn't put that on the slide, but I should have. It starts April 1st, unless you are in Model 2 or 4 of BCPI or in Model 1, an episode initiator in Model 2 or 4, or you're in Model 1. If you don't know what BCPI is, you're probably not in it, but that's Bundled Payments for Care Improvement. Now, hopefully you can read this slide. It's small font, but this is a list of the MSAs that are included in the model. I'm not going to read all 67 of them, but if you're in one of those metropolitan statistical areas and you're not a BCPI hospital, you're in. Now, I am not an accountant, and I don't perfectly understand how they calculate the target price, but I'm getting a pretty good idea. And it's a blend of the hospital historic data and regional historic data. So they look at how things have happened over the last 3 years, and then come up with, and then there's a discount factor that's applied, and I want to say it's like 3%, where they look at the historical costs and then take off a reduction that's in there. Initially, you're going to be based 2/3 on what the hospital's history is and 1/3 on the regional. That's the case in the first couple of years of the program. In year 3, that flips, so it's 2/3 regional, 1/3 the hospital. And then after that, it's regional only. Now, this is initially only a 5-year program. After 5 years, in theory, the thing expires, but we'll see what happens there. There are some weird calculations if you're a low-volume hospital where you don't have a lot of joint replacements, if you've merged or split or done something like that. We're not going to get into those details. Now, there are some caps on the amount you can owe and on the amount you can get in a bonus. In year 1, you can't lose any money. You can only get a bonus. And in year 1, you can get a bonus of 5%. Thereafter, the bonus, the most you can get and the most you can get docked are the same. 5% in year 2, 10% in year 3, and then 20% in years 4 and 5. Now, this is a really big thing. We call this a bundled payment, but it's not. It's really a weird setup, actually, because the hospital is going to be responsible for all of the costs of the care. And the hospital can, but is not required, to reach out to other organizations to enter into a relationship with them. And we'll talk about sort of some of that key lingo here. So the people, the other care providers, physicians, nursing homes, therapists, are referred to as collaborators in this rule. So that'll be a term we're going to hear a lot. Now, other care providers are not at direct risk. So this is a key point. The hospital is going to get docked or bonused based on how the total cost of the bundle of care compares to the target. If you're anyone else, if you're a physician, you're a physical therapist, you're a skilled nursing facility, you get paid exactly the same way you always have. Nothing changes. And you are not required to enter into any relationship with a hospital here. You don't have to be a collaborator. You can bill as you always have. And hospitals are fully at risk. If you run up a big therapy bill, the hospital is going to be bumming because that's going to go towards their cost, but they can't do anything about it. And that's not a little counterintuitive. That's extremely counterintuitive, and it's how this thing works. So no one other than the hospital is at direct financial risk from CMS. The only risk you get is what you enter into if you do a participation agreement. And a participation agreement is the contract that a collaborator will sign with a hospital. And it's like a gain-sharing program. You'll sometimes hear them called alignment tools. And it's something that hospitals and physicians, or really hospitals and nursing homes and others, can enter into. So this is going to have a big practical impact. The next couple slides, I just want to do a little bit more lingo, because there's a lot of it in here. I personally think that's designed to confuse people. So the participation agreement, which is sometimes called the sharing agreement, it sets out the terms in which any economic risk is shared. So collaborators can include anyone who's on this slide. So if you're unfamiliar with these acronyms, a skilled nursing facility or a nursing home, home health agency, a long-term care hospital, an inpatient rehab facility, a doctor, or they use PGP for physician group practice, or acronym David has a hard time pronouncing, a non-physician practitioner, and then any outpatient physical therapist, occupational therapist, or speech-language pathologist. So any of those folks can enter into an agreement with the hospital. Alignment payments are the terms that we use if money is due back to CMS and the hospital is requiring the collaborator to return money to the hospital. So let's say the hospital's costs exceed the target, the hospital has to return money. It is possible for the collaboration agreement to say, you, skilled nursing facility, have to share in that loss and refund money to the hospital. That's called an alignment payment. A reconciliation payment is a payment that CMS makes to the hospital if the hospital comes in below the target. So gain sharing is a term that's existed before this rule, but the rule defines it as a payment from the hospital to a collaborator that is made either as part of a reconciliation payment, that is, a payment that results from beating the target cost, or from internal cost savings. So even if the hospital doesn't beat the target costs, there can potentially be internal costs savings that the hospital chooses to pass on to participants. And then they use the term repayment for the money that the hospital gives to CMS. So internal cost savings have to be measurable, actual, and verifiable savings that are done by only the hospital. Any other savings can't be paid out as part of this program. It's got to be a hospital saving in order for it to be shared. Now, another type of agreement is out there. So you're going to have the hospital, which will enter into potentially relationships with physicians. Then the physician group might have, and is going to need to figure out how it distributes the money. That is done with what is referred to as a distribution agreement. And so that covers how money within a physician group is distributed. Another term that's bandied around in the rule is called a practice collaboration agent. What's nice about that is it's a PCA, which of course is also a personal care attendant. Why would you try to pick a unique acronym? So a practice collaboration agent is a doctor, a non-physician practitioner, or a therapist who's got a distribution agreement with a physician group practice as opposed to contracting directly with the hospital. So if a clinic enters into an agreement with the hospital, it will then have a bunch of practice collaboration agents. And then finally, there's the NPRA, which is the net payment reconciliation amount, which is the amount of money that's paid to the hospital or paid from the hospital to the government. Now, all of the payment here is driven by an episode of care. And so what goes into the episode of care is key and really shocking to me. The episode of care here is incredibly broadly defined. So remember, the hospital is going to be responsible for all the costs in the episode. So what's in the episode? So I'm going to skip between slides for a second here. Here's the list of everything that's in the episode. Physician services, hospital services, IRF. But you'll see some things on here that will boggle your mind. Look at number 13, hospice. Huh? You think, what joint replacement people are eligible for are on hospice? That's going to be pretty rare. That's one of the crazy things in here. So CMS has said they want this to be comprehensive. And so if you go for mental health or chemical dependency treatment during the 90 days following discharge as a Medicare patient, those costs go into the episode of care. So what does that mean? That means that the hospital will potentially lose, if those costs are high, well, those are going to increase the total outlay and potentially result in the hospital failing to meet its target price. Now remember, they're using historical data to figure out how things work. So if going forward, the same percentage of your patients get mental health or chemical dependency or hospice care as in the past, in theory, your target price will take that into account. Now remember, the target price is partially regional and partially you. So it isn't just what your historical practices are, it's going to be what your regional historical practices are as well. But there is an interesting question in my mind as to whether this is a form of rationing and whether this creates a strong incentive for you to reject a joint replacement patient who is going to incur other medical expenses. Now, some of these you can't foresee. I am assuming that very few surgeons put joints in people who are currently on hospice. But if you put a joint in someone and 3 weeks later they're diagnosed with a brain tumor and they go on hospice, that hospice care goes into the calculation for the episode of care. Like I said, I think this is crazy. I really kind of believe that this is a form of rationing and that they're trying to create a financial incentive for you not to do joint replacement on patients with comorbidities. To be fair to CMS, they say that is not their intent, and in fact, as we'll talk about in a little bit, they can penalize you if you try to cherry pick your patients. But economically, that incentive is there. There are some services that are excluded from the episode. I've stuck a few of them on this slide. You can kind of read through it. So these are things that are pulled out, but by and large, almost everything is in the bundle. Oncology admissions, trauma, and certain chronic admissions are carved out, but much more stuff is in than out. So a lot of E&M services, if the person got an ear infection, those E&M services are going to be in. All right, so some frequently asked questions. These are sort of more big strategic questions. So can a hospital say to a patient, you've got to use this therapist or this doctor or this skilled nursing facility because we've entered into an agreement with them? The answer is no, they can't. Hospitals are forbidden from requiring patients to use particular vendors. The rule is very explicit that you must give patients freedom of choice. So a hospital can enter into a collaboration agreement with the Glazer Clinic, but they can't tell the patient they have to go there. They can tell the patient that it would be nice if they went to the Glazer Clinic. And in fact, because, as we'll see in a little bit, they're required to tell patients about all of the organizations they've got agreements with, you're going to have to give some sort of notice to the patient that says, we've got this relationship with the Glazer Clinic. And you can say in there, it would be great if you went there. But you can't require it, and you can't even really incent it in any material way. So could you fire a patient if they go to some expensive vendor? The rule seems to suggest that maybe the answer is no. It's not explicit there. What it says is you've got to give freedom of choice, and so I think the answer appears to be no. There's something extremely unfair about that, and you can generally fire a patient, and I think there's ambiguity there. I think this is going to be an area where we're going to be looking a little. And I should say, this rule came out, I spent my Thanksgiving weekend reading it. We're still learning things about it. This is still very much a learning process. And you generally can fire patients who are non-compliant. It's just that you can't require them to go to a particular vendor. So can a hospital go to a physician and say, hey, you need to sign this contract? Well, this is a bit of a trick question. The hospital can't make anyone be a collaborator. They can't say, you need to share the risk with us here. They do not have that ability. In fact, on the contrary, they're explicitly forbidden from doing so. If the physician or therapist agrees to be a collaborator, then there must be a written agreement. And so in that sense, they can require a contract, but only if the professional desires to be a collaborator. So if you're a physician, can you share the potential gain without sharing downside risk? And the answer to that is absolutely yes, you can. The collaboration agreement does not have to be both ways. It can be upside only. And if so, a physician is free to say, look, I'm not willing to share the risk. And there's a certain logic there because there's a fair question. How much can an orthopedic surgeon control costs for hospice care or other things that might happen? So it's totally possible that a hospital could blow through the target price for factors that are well beyond really anyone, either the hospital or the physician's control. So if you're a doctor, you may not want to touch that downside risk. Now, as I alluded to earlier, the hospital is required to get a beneficiary notice. And this is a place where we're going to move a little bit from the 30,000 feet to the weeds. So when you give a notice, you have to do that at the later of either the patient's admission or the decision to perform joint replacement. So that's when the hospital has to give the notice. So they can do it when the patient shows up, or if they showed up for something else and the decision is made during the stay, they do it then. You've got to provide details on the program and how it's going to affect care. And I will just say it here, going through this rule, which gives me a bit of a headache, the notices and the contracts have a bunch of hoops to go through. This is a detail-oriented person's dream and a big picture person's nightmare because there's just a bunch of junk you got to do. You've got to notify them of the fact that they can go anywhere. So you're going to have to tell them that they are free to choose any provider they want. And as I said before, you can say, you can recommend, but you cannot require they go anyplace else, and you have to tell them they're free to go wherever they wish. You have to explain how they can access their care records, and there's the program that I have to admit I was unfamiliar with until reading this, the Blue Button EHI, and you have to explain how that works. You've got to tell them about all the protections that apply and how they can report quality concerns, and you have to list all of the collaborators. So this is going to be a honkin' notice. The hospital is not the only person or entity that has to provide a notice. Collaborator physicians have to give a notice, and they have to do it as soon as there's a decision to do the lower extremity joint replacement. I apologize if I didn't, so LEJR is lower extremity joint replacement. So they've got to tell the patient in writing, and they have to give an explanation of the structure of any contracts they've got on this and any sharing arrangements they have. Now remember, you're only a collaborator physician if you have an agreement. So if you're a physician in a CJR MSA, I wonder how many acronyms I can put in this sentence. So if you're an MD in a CJR MSA, you do not have to give the patient a notice if you're just doing the surgery and you don't have any kind of collaboration agreement with the hospital. It's only once you enter into, basically, you aren't covered by this rule as a physician unless you have a collaborator agreement. And so that's kind of an important thing to think about. Anyone other than the hospital who's listening to this, none of it applies to you legally. There might be practical impacts, but no legal impacts unless you enter into a collaboration agreement. So you've got to, if you're a non-physician, you've got to reveal your collaborator agreement, and you've got to have a discharge planning notice that addresses non-covered care. Now, there are a bunch of limits in the rule on how the risk sharing can happen. One of the biggies is you have to set the terms that you're going to operate under before any care is furnished to a patient. And you also have to agree on specific quality criteria. It doesn't say what those are, but you've got to put quality factors in the agreement, and if they have to be a condition precedent to payment. There's also a limit, and this is really important, so if you've got them printed out, this is a thing to circle. And I struggle with articulating this one, so bear with me. The payment to a physician can't be more than 50% of what the physician makes off of the physician fee schedule payment for services to CJR beneficiaries. So if the doctor saw 10 beneficiaries and the physician fee schedule payment for each one was $500, the doctor got $5,000 in Medicare Part B payments. The most that they can get as a distribution payment from the hospital is $2,500, all right? So no matter how much the hospital saves, either through being below the cost target or through lowering its costs, that's a firm cap on the amount of money that can be paid to a physician. I believe, and I'm embarrassed to not be 100% sure of this, but I believe that the cap only applies to payments to physicians. Physician practices, so it would also apply to non-physician practitioners, but I don't think that there's a comparable cap for any SNFs or therapists. Another limit is that only physicians who actually perform services to CJR beneficiaries for at least one episode of care can get any gain-sharing payment. So if you are a multi-specialty group, and the multi-specialty group enters into a contract with a hospital, and there's a $300,000 payment to the group, you can't take that $300,000 and throw it into your comp formula. You have to allocate it to specifically physicians who perform services to CJR patients, and no doctor who gets it can get more than half of what not they received, I guess, but what the Medicare physician fee schedule payment was. So there's a bunch of math that has to go into this. All these transfers have to use electronic funds transfer. That's specifically in the rule. Now, other limits that exist. So remember, the hospital can choose to try to require participants to pay money back, but they can't take money back from a collaborator unless they own money to CMS. and they can't ever take back in aggregate more than 50% of what they owe CMS. So the hospital always has to be responsible for at least half of what it's repaying to CMS. And no single collaborator can be on the hook for more than 25% of what a hospital owes CMS. Now remember, as you go out 4 years, a hospital can lose up to 20% of the money here. I mean, there's a big potential downside. And no payment can be made to a collaborator if the collaborator is, and this is a quote, subject to any action for non-compliance with this part or the fraud and abuse laws. So we don't know exactly what that means, but it's a firm limit on payments to collaborators or physicians. So there are also you've got to use GAAP, and then something I had never heard of before, the yellow book, the yellow pages, which I knew were outdated, but that's the government accounting standards have to be used when you calculate the payments. And you have to have actual hospital savings have to be based on the basis of the cost-saving payments. It can't be based on savings in therapy by therapists or by SNFs or by physicians or anything else. You can, however, use both hospital savings in meeting the target price and then also internal cost savings. This is probably pretty obvious, but any payment on internal savings has to be consistent with STARK, the anti-kickback statute, and if the hospital is tax-exempt, any tax-exempt rules. Now, we're in weeds here a little bit longer, so I apologize, but these are important weeds. Some of these are weird. The hospital has to update its compliance program to specifically include mention of the CJR program and its oversight. The board has to have oversight of the CJR model. So you're going to have a board report on this thing according to the regulations. You have to have written policies for selecting collaborators, including quality. So you can't just go enter into these things. You need to set up criteria as to how you're going to do it before you do it. It's logical that they can't be directly or indirectly referral related. That's no biggie. But this notion that you have to have written established policies, that's, I think, relatively unique. BCPI has some stuff like this, but if you think of what most of the contracts we do, you enter into a relationship, this notion that you have to ahead of time have written criteria, that's new. And I think that that's going to trip some people up, and it's why the weeds here are important. So the Collaborator Agreement has a whole bunch of junk in it that you got to do. This is when I say it's a detail-oriented person's cup of tea. I don't know that I'm not going to read through each of these things because you can look at them in the slides, and frankly, but you can look what you need to put in there, including success metrics and how you're going to do this, you have to have details on the management and staffing. You have to have a requirement to comply with all the rules. Now, it doesn't say, is it okay to just say you will follow all the rules, or do you have to, in essence, attach a copy of the federal regulations to your thing? It's a little nuts. Neither of them sounds particularly good, but I think if I had to pick, I'd actually attach it as an exhibit as opposed to trying to re-summarize them all, which just seems like a bunch of work. So there are some things in there that are kind of silly. You have to have an explicit requirement that you're in compliance with the Medicare enrollment provisions. The collaborator has to have a compliance program. So generally speaking, a physician practice doesn't have a compliance program. If they enter into this as a collaborator, they do. For those of you physicians who are listening and don't have a compliance plan, first, you probably should. Second, we have a webinar that can help you make that happen. If you need help finding it, send me an email. Remember, all of our past webinars are available. They're all free. You can send them to whoever you want. I can send you a link to them. So if you've got someone who wants, for example, to see this later on, if you're like, oh, someone should have suffered through David, they can watch it for free. If you have internal cost savings going on in there, you have to have very specific detail on how you're going to do that. Everything from the quality criteria to an explicit statement that if any data is false or fraudulent, you'll recoup the money. So these are not simple little one-page agreements, unfortunately. There's also a whole bunch of stuff that you have to document, and this is crazy. This one's weird. You have to, so first, You have to list all of your collaborators, including their addresses, and put that on the website. That's not so weird. For whatever reason, the regulation says that that has to include both your current and your historical collaborators. Why on earth anyone cares who you collaborated with 3 years ago, I do not know, but that's technically in the rule. So your website has to have that. You have to document every payment you make, including the reason you did it, the amount, and the date. So this is a record-keeping nightmare. Your records have to show that you verified the Medicare eligibility of all the collaborators. I don't even frankly totally know what that means. Is it checking the OIG exclusion list? Are you checking that they have UPINs? I don't know what that means. You have to prove that you have the ability to measure and track the cost savings. That has to be part of your documentation, is some sort of proof. I'm not making this up, I'm just relating what's in the crazy rule. You have to have documented your plan for tracking the cost savings, information on what accounting systems you use. You use an accounting system, why you have to write something about it, I don't know. You have to describe your current health information technology program and have your plan for tracking Gainsharing, and then you have to keep documentation of any recoupments that you do because of overpayment or false or fraudulent data. So lots of record keeping. And you have to, I don't know if I was smart enough to put this on the slide, you have to keep it a really long time. It's like, I want to say 10 years after the last payment is received under this program. Some big picture questions. This is first, we're back to the big picture for a moment. If you're a physician, you need to realize that there's a bigger cap on your gain than your losses. And the reason for this is, remember, no matter how good things get, you can't get more than 50% of what you received under the Medicare fee schedule for your work with these patients. That's a ceiling. There isn't a floor. So if you decide that you're willing to share risk with the hospital, you might want to have some floor in there because you've got a cap that comes from the government. The big picture, perhaps the most important thing if you are a physician or a SNF or someone else entering into a collaborator agreement, you've got to decide if you've got control over whatever it is that's going to determine your payment. Because the short answer for some of this stuff is you don't. And so make sure you recognize if you're taking risk, what can trigger that risk. If you're a physician, if patients generate a lot of therapy, and remember, you can't make them use your therapist. They go someplace else, and that therapist is aggressive and does a lot. That can cause the hospital to go over the target price, and if you've got downside risk, you're on the hook for it. The hospital has no ability to control that, but if you're the physician, you can at least choose not to enter into the agreement. It's always good to think about what's the worst that can happen. Now, here's a question I don't have the total answer to. Can you have a multi-party agreement? I would think you can. It's probably difficult, but I think it would work. All right, if you're a physician group and you do this, how do you distribute payments? And we've covered this a little, but it's worth a reminder. Only doctors who are involved in the episode, in at least one episode of care, can get any of the payments. The payments don't have to be equal, and I would say it's going to be very difficult to make them be equal because, remember, no one can get more than 50% of what Medicare allowable was for those services. So if you had a doctor who only did one joint replacement procedure, they can't get, more than half of their physician payment, of the fee schedule payment for that amount. So this is interesting. I sometimes get asked, hey, can we pay the people who are more heavily involved in this program more? That will come up sometimes in the Gainsharing or co-management context. Someone will want to pay a really busy physician more than a less busy physician. And sometimes people get nervous because they're thinking, well, we can't pay more for busy people because that's at least indirectly based on the volume or value of referrals. I think that analysis isn't always spot on, but it's an issue that's out there. In this case, I think there's a pretty darn good argument that not only can you pay more to someone who's busier, but basically you have to because it's the only way you can distribute this money. So I think that this program sets up a pretty strong argument that the most active physicians must be paid more, not only can be paid more. So another question that gets asked a lot, and this is one that's going to apply both in the CJR context and also in the gain sharing context. Can you have a long-term payment? And I maybe should have talked about this more in the gain sharing context because it's where it comes up. The conventional wisdom is that you can only have a one-year gain sharing deal. And I hear this all the time. I've had arguments with more people than I can count on this. That statement is, and I'm going to say this categorically, it's wrong. There's no doubt about it. So it's not often as a lawyer that you can make categorical statements. You know, we're often couching things and it depends. So why do I know that you're not limited to 1 year in a gain sharing payment? Because there's an advisory opinion on this topic, which is Advisory Opinion 1222, which looked at a management agreement which was a 3-year term and which the government described as, quote, limited in duration. Now, to be fair, advisory opinions aren't binding on anyone that's not a participant, so I suppose technically that is not a guarantee that anyone can have a 3-year term. And I would agree, not all 3-year terms are going to be okay. But anyone who insists that the gain sharing can only be for 1 year needs to look at that advisory opinion. Now, one of the lawyers that I had a long argument with was saying, well, that's really a co-management agreement. It's not a gain sharing agreement. And they weren't reading the opinion very closely because it talked about the savings that were in there and how they were being split. So ultimately the test is the payment reasonable? And one concern is if you set a cost benchmark in 2016 and you're making payments in 2018 based off of the 2016 costs, there's the question, is that reasonable? And that's going to have to be analyzed on a case-by-case basis. You know, there's certainly going to be more risk the further out you go that maybe you should be rebasing your cost criteria as time goes on. But there's argument for a multi-year payment. Okay, complete subject change. What are the quality metrics in this puppy? So there is a measure called the THA-TKA complication measure, which looks at acute MIs, pneumonia, and septicemia within 7 days of admission, surgical site bleeding, pulmonary embolism, and stuff like that. Those scores are 50% of the quality metrics. There's also the, I think it's the HCAPAS, I don't know, it's the Hospital Consumer Assessment of Healthcare Providers. And it's an interesting survey to look at. And anyone who wants to enter into one of these agreements, you better read the survey, because you need to know this is 40% of the quality metrics. And one of the things that's in there is the cleanliness of the bathrooms, you know, pain management, how quickly nurses respond when you press a call button. Those are all factors in there. And so I've watched physicians sign gain sharing agreements where this is a measure without realizing, you know, you're now on the hook for how quickly nurses answer the call button. So that's 40%. And then whether or not you voluntarily submit various risk and outcome data is 10%. Collaborators need to know that they may not be able to influence all of these metrics. The metrics are then converted to points. And this is going to be a bit of a generalization because we could spend, well, I couldn't, but one could spend 30 minutes detailing all of the quality metrics and how they work. But basically, if you're in the bottom 30% around the nation on either measure, that's probably going to prevent you from receiving any reconciliation payment for beating your target price. You have to be in the top 70% of hospitals in both of those measures to get a payment, generally speaking. It's a little too simplistic, but pretty close to right. Also, if you improve your quality by more than 3 deciles, and so that's going from the 10th percentile to the 40th percentile, you can get quality improvement points for that. So a lot of this stuff is done on a curve, and being in the bottom 30% is a problem. Okay, we're getting pretty close to the end of CRJ, and then we'll be moving on to gain sharing. So hospitals hospitals can get penalized if either they or a collaborator do anything on this slide. Now, going back, remember, this rule really applies to hospitals. So collaborators, you know, the physicians and rehab facilities and therapists aren't covered by this rule. They're only covered by the agreements they sign on the rule. So if someone's avoiding high-cost patients, I talked about this idea that maybe you won't do people with comorbidities. Well, in theory, CMS can penalize you for avoiding those people. That seems contrary to the whole financial incentives here, but they can. If you target low-cost patients, if you provide too much or too little care, you restrict choice, all of those things, there's a range of penalties that they can apply to you, ranging from taking money from you to throwing you out of the program. If you get a False Claims Act investigation or any demand letter under a civil sanction authority, even if it's completely unrelated to this, to CJR, they're still allowed to penalize you in CJR. That is another one that shocked me. You can offer the beneficiary incentives, but there are some limits in here. So first, they have to be in kind. They have to be offered by the hospital or its agent, and they have to occur during the episode and be connected to the episode. It has to either be a preventive care item or something that's designed to advance a clinical goal, and the clinical goals are on the next slide for managing health. You can't link whatever incentives you want to offer to receipt of services from a particular vendor. It's back to the freedom of choice thing. So you can't say, if you go here, we'll give you this iPad that you can use to track your therapy appointments. You can't advertise it, and you can just give them notice when it's time, and you can't charge some other Medicare program, government program. So the goals in mind for these things, and I've struggled a little to think of the kinds of things you might be giving out, but it's exercise balls, and I suppose if you thought that there was an app that people could use and stuff like that, it has to be for adhering to a drug regime or care plan to reduce readmission, and measurement of chronic diseases and comorbidities. So if you've got something that's going to help a diabetic, control their blood sugar, that in theory can be there. If whatever it is we're talking about is technology, it can only have $1,000 in retail value per episode. Now, so an iPad, I think most of those these days are under $1,000, but it's in retail value. You can only keep it during the episode, so how do you figure out the retail value? Is that the sale value or the use of 3 months of iPad? You have to give them the minimum necessary to advance the goal, and if the thing you give them is worth $300 or more, it has to stay in the title stays with the hospital, and they have to attempt to get it back and track all of their efforts to get it back. Any incentive you offer over $25, you have to document, and you have to keep these records for 10 years after the end of participation or the completion of an audit. Okay, so just the big picture here, this is going to be, I think, a big deal. How much of a big deal it'll be outside the 67 metropolitan statistical areas is yet to be seen. And it's a 5-year program. Would they try to stick it to anyone else before those 5 years are up? Who knows? But this is weird because hospitals have responsibility, but they don't have power. It's like being a general contractor where the sub doesn't work for you. And that's a scary place to be. So I think this is hard for hospitals. And if you're the hospital, one of the things you're going to be thinking about is how can I gobble up and control all of these other professionals who are providing services, keeping in mind that even if you employ all of the physicians and these therapists, it has to be literally all of them because you can't make the patients go to the ones you employ. All right, so we'll spend the last 17 minutes talking about gain sharing generally and then answering questions. So many of you know my hobby is storm chasing, and I think of gain sharing as a little like this. It's kind of pretty, it's kind of cool, and it's potentially dangerous if you do it wrong. It's not a reason not to do it. And I assume some people, this is maybe a bad analogy for some people because I think of storm chasing as terrifyingly dangerous. It's not if you know what you're doing. It's totally safe. And that's how I would describe gain sharing. As long as you know what you're doing, it's safe. Don't do something stupid. So what is it? And this is an interesting lingo thing because there are more terms tossed around. I think of everything on this slide: gain sharing, shared savings, co-management, alignment payments. It's really the same thing. I liked the term shared savings because it sounds positive. Of course, then Medicare used shared savings to describe the ACO program, which makes things confusing. Co-management can, in my mind, be broader than shared savings or gain sharing because I think that generally that applies only to direct cost. I would use those terms for economic costs being reduced, whereas co-management may get more into quality, but I think that's somewhat arbitrary. I don't care. I mean, what you call it doesn't really matter. I think the reason I like shared savings is it sounds touchier and feelier than gain sharing, which sounds like it's potentially greedy. So the goals are simple. You want to reduce waste. You can do this by, avoiding drug wastage, by, a common one I hear from the orthopedic surgeons I work with, by just not opening by not opening instruments. The cost of sterilizing an instrument can be huge, and I know there are hospitals that save, $1 million or more a year simply by limiting the number of instruments that are opened during procedures, or avoiding drug waste and things like that. You can get things from standardizing your equipment. On-time starts, which is a quality payment, but it's also an efficiency payment. Kosher, popular, totally okay. If you can lower your implant costs, and I've heard some really creative ways of doing that. There are some really creative programs for lowering implant costs, totally kosher. And it is now crystal clear, if you can get the physicians to participate with you, if you're a hospital and the physicians participate, you can compensate the physicians and share that savings with them. So price isn't always everything, as you'll notice by the little tornado in the background in Foster, Wisconsin there. Now, the government worries a lot about whether people are what they call stinting, which is using lower quality products or picking certain people and things like that. The government doesn't want you to do that. They're a giant fan of transparency. And I think one of the best risk management tools in any of this stuff is openness. If everyone knows what's going on, it lets you say, we weren't hiding this from everyone. We were transparent. And the government regulatorily speaks of that, but practically, I love it. They want quality measures. That's big in CJR. And it's big, and I had to do a double take to make sure I didn't turn it into an airplane. It's big in, it's useful in any kind of gain sharing program. The labels don't matter, the law does. And there are a bunch of them. So first, there is a federal law out there that makes it a felony to do any payment that's intended to reduce services to a Medicare beneficiary. And until about 1999, the government used to say that that made gain sharing illegal. Now, that law didn't go away. It didn't change. And if you went and looked at CMS data from public releases from 1995, they would say gain sharing is illegal. And then suddenly, around 2000, it all flips without any change in the law. And there are now, I think, 17 advisory opinions looking at gain sharing that all say gain sharing is legal. So this is another thing I will say categorically. Gain sharing can be illegal. That is not to say all gain sharing is legal. Those are different statements. But gain sharing itself is potentially legal. And that is crystal clear, despite the fact you can still find lawyers who will say that it is illegal and others that will say it's risky. And I guess on some level, it can be, you can get into trouble, so there is risk, but there's risk crossing the street. So, so we've got these 16 advisory opinions that start in 2001. And not only that, but the Federal Register had, about a year ago, a statement that said, pending further notice from the OIG, gain sharing arrangements are not an enforcement priority for the OIG unless the arrangement lacks sufficient patient in-programs standards or safeguards. So they're not really looking at this unless you're going rogue. And what they want to see are caps on payments, some sort of utilization target, disclosure, and they would acknowledge that hourly payments are lower risk than some other things. So one of the questions we get asked a lot is, how do you split the savings? Let's say you currently use device A, and the cost for device A is $1,000. And you're going to go to a generic device or a device made by a different manufacturer, and it costs $600, and there's $400 in savings. What happens to that savings? Now, most of the advisory opinions describe a situation where those savings are being split 50-50. That is not a requirement. That's an option, but not a requirement. Now remember, under the CJR program, you can't, that however you split it, that the payment to the physicians can't be more, if this is a CJR related payment, more than what the 50% of what the physician's getting under the fee schedule. But in any other context, let's say we're talking about cardiology or other surgeries that aren't part of the CJR program, a 50-50 split is going to be kosher. Well, that was too categorical. Is probably kosher. That's sort of the norm. But it just seems to be the norm. There's nothing that says higher is illegal or that lower is more legal. That's kind of where we're at. You do have to know the 4 big laws: Stark, the anti-kickback law, tax exemption if you're a tax-exempt nonprofit, and antitrust. Let's start with antitrust, because that's one you may not think of here. The main way antitrust is going to come up is if there is some collusion on either the purchasing of stuff or getting certain people out of the market. So you just have to be a little wary of that. Stark is probably the biggest one here, because remember, under Stark you have to meet an exception. The exception you're almost certainly going to be trying to fit in is the fair market value exception, which means that the payment to the physician has to be reasonable for the work he or she did. And so the risk is always that someone says, how much work did the doctor do to really lower that implant cost? That's, if someone's going to attack a gain-sharing program, that's how they're going to attack it. And under the kickback analysis is similar, with it being a criminal statute, but there it is intent-driven. And so what makes Stark scarier is that even if your intent is pure, if the payment isn't at fair market value, your good intent doesn't save you. You still potentially owe $15,000 a claim. We've talked about the long-term payments, so I'm going to blow through that. So when you're talking about co-management generally, a few things. So first, there are some companies out there that have these programs, and part of their programs is usually setting up an LLC. And if a whole bunch of different practices are coming together to manage a hospital department, an LLC is a good idea. But if you are a single group or a single physician and you're going to manage a hospital service line, I think setting up a new entity is an unnecessary complication and actually slightly adding to the legal risk. And I generally wouldn't do it. So you have to, do you need a new entity? If you've got a whole bunch of players, you probably do. But if you're one group contracting with one hospital, you probably don't. Make sure your terms are clear. And this is advice especially for the physicians who are doing this. Think about whether the payment factors are in your control. Like, it's common to see Press-Ganey scores as factors in a co-management agreement. And a patient might be mad because the registration process in the hospital was slow. So is that going to come back to bite you? Turnaround times. Well, an on-time start is not purely in the physician's control. There's anesthesia. So you want to make sure that when you write these criteria, it's written as the physician is present and available for an on-time start. That's good for the physician. The case starts on time. Well, what if the nurse isn't there, or what if anesthesia isn't there, or what if the patient isn't there? Those are factors outside of the physician's control. And I think the place that co-management deals often go off the rails is having measures that are inconsistent with what the physicians can affect. Okay, last thing we're going to do, and before we do questions, is I want to give an example. This is a real-life example of how gain sharing can go wrong. So is gain sharing, I think gain sharing is a great idea. I am a big fan of co-management. I think hospitals can come out ahead. I think physicians are often happier because they've got management control. They can get paid a little more. I think things often run more smoothly. So I am a giant fan of co-management. But boy, you can screw it up. It's sort of like, if you look here, if you look in the lower right corner, there is a car. And if you look just to the left of the car, there is well, here I can draw on this thing. There's an area, so you see the lightning bolt. It's easy to get distracted by the lightning bolt. But if you look over here, if I can get this to work, right there, well, there is a tornado on the ground. There's a big cloud of dust. You don't want to accidentally drive into the tornado. So what do I mean by that? So this is an excerpt from the Des Moines Register. So according to her lawsuit, Kathleen Davis suffered a significant complication after having a Medtronic pacemaker implanted at Methodist in 2004. She said her cardiologist made a startling confession when asked what happened to cause a twitching in her abdomen. The cardiologist told her that she probably would have fared better with another brand of pacemaker, but that the Methodist administrators had leaned on him to install the Medtronic model to help the hospital collect on what he called a kickback deal, the lawsuit said. Now, obviously, this is a lawsuit. I don't know the facts entirely of what's going on in here, but boy, this is a nice illustration of how things can go wrong. So patient has problems, goes to the doctor, and the doctor, wishing to say it's not my fault, says, it's not my fault, the hospital made me do it. Why, how anyone thinks in that situation that the shifting the blame to someone else is going to work is a mystery to me. So Frank, the physician, has made no attempt to comply with the contract. I'm prepared to reschedule his devices to be in compliance with the contract, wrote Tim Nelson, a hospital manager who has since left the company, in one email obtained from the court file. And here's the part you're going to love. In another email in the court records, Butts, another administrator, wrote, Frank did say that he would abide by a contract that paid him money for compliance. In the email, which Butts wrote to Methodist Chief Operating Officer David Stark, you can't pick the names better for this thing, he said, isn't there a joke along these lines? Now that we've established what he is, we're simply negotiating over price. So to me, this is an example of the horror story of what can go wrong, which is you've got emails basically mocking physician behavior and a physician blaming mistakes on the hospital. Emails are so dangerous, partially because humor isn't clear, or it is clear and it comes back to bite you. All it takes is one email that says, hey, if you don't do a co-management deal with us, we're going to take our cases to the hospital across the street. That's enough to basically set up a potential felony if you do the deal. And so I guess from a risk management standpoint, A, avoid email, but B, you have to avoid making threats, and you have to avoid, kind of gain sharing as leverage. Especially for physicians to say, we'll take our cases elsewhere, that comes with real peril. So the bottom line, you got thinking about the bottom line. I think entering into some kind of relationship between hospitals and physicians is going to be essential in CJR states. Doctors are going to want to hesitate a little bit, but for hospitals, you're going to want to do it. In all other settings, I think it's good for everyone involved. How you say things matters. Bundled payments are likely here to stay, but remember, I don't think CJR is technically a bundled payment. It's really a hospital at risk for cost overruns, not a bundle. If you do gain sharing, I think you want to be wary of direct involvement by device companies. It's okay to get discounted devices. I think that's a great idea. But I'm a little hesitant to invite a device company into kind of a partnership on this sort of thing. I think that that's potentially dangerous for everyone involved, including the device company. It's great to save money. And is there risk with this? Yes, but it's no riskier than countless other activities that hospitals, physicians, and therapists enter into on a day-to-day basis. If you've got a joint venture to do athletic trainer outreach, you can get in trouble for that. And really, I don't think that gain sharing is materially any different. So I'm surprised we don't have a ton of questions so far, but we've got a couple. So why would a speech-language pathologist be part of the bundle of services delivered in joint replacement? A great question. Really good question. And it's because the bundle of care is defined in a way that's completely insane. Why would hospice be part of an episode of care? It's because they said, what they claimed is, we want to be comprehensive because we want we want the big picture to be thought about here. Logically, is it part of it? No. But what they'd say is, people might be, and I don't even get this, you might be getting a joint replacement and maybe you've had a stroke or something like that, and so that might be part of the care. But they talk dialysis, okay? Dialysis is part of the bundle. Let me see. But at least some parts of the dialysis stuff I think are. I'm trying to remember. Back in the proposed rule, I know that was in there, so I could be screwing this up. But I remember reading this in the proposed rule and going, this is insane. And they said, well, people who are on dialysis are more likely to need joint replacement, and so we think that there's sort of a correlation there. And you go, there's maybe a correlation, but there's no causation, and it's crazy. So excellent question, and the answer doesn't make any sense. can hospitals contract with the individual doctors within the group as opposed to the group itself? And the answer to that is yes, they can. That is an option that's available. And there's an interesting question if you've got a multi-specialty group, if that's a better way to go because of the weird, I mean, ultimately, in some ways, the only beneficiaries of this can be people who are providing services to the joint replacement patients. Now remember, because of the broad definition of the bundle, it isn't necessarily just orthopedic surgeons, oddly, because that's where you get into a speech-language pathologist could be part of this. So that's all we've got on questions. So I'm going to wrap it up here. As always, anyone here is always happy to help you on stuff. Remember, you can, why on earth you'd want to listen to this again, but if someone else who wants to listen to this, in a couple of days we'll have the link out and you can forward it to anyone for free. The April webinar is going to be advanced provider-based. That's going to be great. If you've got anyone who deals with provider-based stuff, you're going to want to get them to sign up for that. And then May, the mobile medical apps and things like that. So thank you so much for slogging through this with us. Have a great day, and I'll talk to you soon.